I'd like to introduce Claire Bidwell Smith, who is an internationally renowned author, speaker, and grief expert, who's the author of 3 books of nonfiction, The Rules of Inheritance, After This, When Life is Over, Where Do We Go? And Anxiety, the Missing Stage of Grief. And with that, I will pass it off to Claire.
Thank you so much, Dara. Hi, everybody. I'm so happy to be here. I really look forward to this every single week. I started hosting these conversations in April or late March, just wanting to create a space where we could come together and talk about everything that's going on with what's coming up for us during this pandemic, the death and dying and end of life and kind of existential anxiety we're all experiencing. And I love bringing in a guest every week that knows this space in such a unique and intelligent way. So I'm so thrilled today to have Dr. Jessica Zitter with us. Jessica Zitter specializes in critical care and palliative care medicine and practices at a public hospital in the San Francisco Bay Area. She is the author of Extreme Measures, Finding a Better Path to the End of Life. Her essays and articles have appeared in the New York Times, the Journal of the American Medical Association, and other publications. Her work is featured in the Oscar and Emmy-nominated documentary Extremis, as well as her forthcoming film, Caregiver, A Love Story. She is a nationally recognized speaker on the topic of dying in America. Welcome, Jessica.
I am so thrilled to be here with you, Claire.
Thank you. So obviously that's your bio, but I would love to really have you tell us about yourself. How did you become all of these things? What made you the person who wants to talk about dying in America?
Well, I mean, as you were telling me earlier about your own personal story, you were relatively young and in a formative stage of your life when you came to this work yourself. And I think I could say the same thing for myself. Maybe I was a little bit older than you. I was sort of in my early years of practicing and learning how to be a doctor. And I really realized that there was something that wasn't feeling right to me. And I couldn't quite put words to it because we were really so indoctrinated. I was so busy and I had so much to learn and I had so much to do. And I had all these competencies to acquire. And yet something wasn't resonating, something wasn't feeling right. And it was only when I actually had come through my training and was starting my practice as a young ICU doctor in Newark, New Jersey, that I had the luck to be in an environment where there was a very early stage palliative care team. This was in 2003, and this group had just won a very coveted grant from the Robert Wood Johnson Foundation that I didn't even know was happening in this hospital to enhance communication in the ICU. Again, they called themselves the family support team, but they were the early stage palliative care people. They're still there at University Hospital in Newark. And the woman who headed the group, Pat Murphy, an amazing advanced practice nurse, trained in palliative care, had worked with Elizabeth Kubler-Ross, et cetera, et cetera, et cetera, did not suffer fools. And she did not have the typical fear or she didn't live in that world of hierarchy. She was willing to stand up and say, what are you doing? Why is that patient not well managed? Why is this person writhing in pain? Why are you putting this catheter into a patient that you and I both know is going to die tomorrow? And the long and short of it is, and I talk about this wherever I can, I had an epiphany moment with one day when I was trying to put in this huge catheter into a woman who I knew was dying. And she was standing at the doorway just looking at me, putting her hand to her face and saying, call the police. They're torturing a patient in the ICU. And that moment, it just shook me out of this path that I'd been going along and said, whoa, I got to do something different. And so the rest is history for me. I really started to learn about palliative care, and I became a real zealot for palliative care and practiced both ICU and palliative care, straddling, going back and forth between these two very different subspecialties. In fact, I'll say one last thing before I stop talking, which is that one day early on when I was discovering palliative care, a very renowned head of medicine in one of the renowned medical schools in Boston said to me, I think it's a conflict of interest for you to practice both intensive care and palliative care. Wow. As if I would be less inclined to save someone's life because I was involved in the palliative care movement. So all of that is together.
Yeah. I have chills. Like I told you, this topic and this area is so important to me because my mother died at 18, and it was the most painful experience of my life that I, in some ways, still reckon with, almost 25 years later. And her death was, what we're trying to change now, and I didn't know that at the time. I just thought that that was how things went when someone died. And there was so much pain and confusion and regret at the end of that. And there was so much that I wish we had been able to face and sit with. And then my father had this very different death where he chose hospice, and we were at home together, and it was so beautiful. And so I too have been trying to look at this space for a long time, generally from the side of also helping others who've gone through this and lost their loved one in some way, and are now reckoning with a lot of the things that are trying to change right now. Why do you think, I'm heartened to know that palliative care is really getting a lot more attention these days. What do you think it was that kind of started to move us in that direction?
Wow, it's a really good question. It's hard in medicine, whether even if it's typical things like getting a new medication that really helps heart failure. It takes, I think they say 10, sometimes 15 years to get people to really start to incorporate things that are even very strongly data proven to work in mortality trials, et cetera. So doctors and healthcare systems are not very good at change. They are like a big, huge cruise ship. And particularly when that change involves really looking at deeply held values and questioning them. Because we, in some ways, in this world and in this work, and I can tell you in the ICU, there's a lot of people, some people are going to ding me for this, but there's a lot of smoke and mirrors because there's a lot of fear and anxiety. And I'm not just talking about patients and family. The doctors are terrified. A lot of times it's
well, I mean, isn't the root of what you're taught as a physician to save people, right? So this idea of embracing death, I think it sounds like that becomes a feeling of failure.
Yeah. And if you see somebody struggling in front of you and you can't get them, you can't fix them, you can't get them better, and they're suffering in front of you, you shut down. And if you've got some palliative care person coming in and saying, well, maybe you should think about being more patient-centered and moving into the fear and moving into the panic and starting to enhance your communication instead of pulling away, you might find that very threatening. And many people do. So I think in the beginning, just like I was very resistant to Pat Murphy coming in and saying, why aren't you doing this? Why are you that? It really took a very strong moment where I was able to shed all of these pretenses that I had learned to keep me feeling strong in that environment that is so traumatic. Mm-hmm. And to really just say, okay, I'm putting this all to the side and I need to be open. And I think that more because the movement is gaining, people are starting to listen to it, and hospital administrators understand the value. People are starting to let palliative care, let these principles of palliative care into their lives, and I think are feeling some tremendous relief. So in the hospital environment, there is an openness. It's still, when things are getting stressful, people revert back to these hierarchical and kind of distancing behaviors. But I think there's more and more opportunities for this type of collaboration, compassion, communication to sort of make their ways into these different units. And I think a big part of this is the lay community starting to get more empowered and more educated as they read more and as they say, I don't want that. I don't want that. I want something different.
Yeah, I don't think the change can come just from within the medical community. It has to also come from us, the lay people out here. So this was one conversation about palliative care and end of life 6 months ago. What is this conversation now that we're in the middle of a pandemic? So how is this now? How are we talking about end of life care and palliative care now that we're in this place?
It's so interesting. What happened in the early stages of the pandemic was that most hospitals turned to the palliative care service. When we started to realize the potential morbidity, mortality that was going to come, and sort of the lack of power that we were going to have against this terrifying virus, people started turning to palliative care and saying, help, we need you. We're going to need more of you. We're going to need a palliative. And all of a sudden there was more resources put towards palliative care in many hospitals, not in every hospital, by the way. And there were more ways. I mean, I started volunteering in New York City, for example. They were calling us in. I mean, when would that have happened before?
That's
people, amazing. And it was an amazing experience to do telehealth from 3,000 miles away. But I think that there was this sort of, oh boy, we do need palliative care. Again, still with this, I think, misinformed idea that palliative care is only about dying.
Mm-hmm.
But it's part of what we do. Managing symptoms for patients who are seriously ill and dying is a part of what we do. And that's, I think, why people were turning to us, also to enhance communication and other things that we're very obviously experienced at. And in the lay community, I think what happened was people started to just see their mortality in ways that we Americans are really good at not doing. When you've got a pandemic bearing down on you, you can't help but think about death. And I think people started to do that.
Yeah, I mean, I have been writing and speaking and shouting from the rooftops about grief for, 15 years. And this year has been the busiest year of my life because people really suddenly want to talk about grief. And they all of a sudden, very much in April and May, I probably did 60 interviews between podcasts, newspapers, random things, because suddenly everyone was like, oh, wait, grief, we need to know more about that and prepare for it. And I was like, all along, yes, we could have and should have been having these conversations. And that is something I'm hopeful for with the pandemic, that we will come out of this experience. And I think it's happening, of realizing that we need to be having these conversations before we're even sick, about end of life, about grief, about what our wishes are, all of these things. Kay really wants to know, though, if you could describe the difference between palliative care and hospice, since we have been kind of talking about that.
That's a really good and important point. I think a lot of times these two groups get lumped together, and it's really important to understand that they're not the same thing. In a way, I look at hospice as a subset of palliative care. The high-level palliative care philosophy and what we do is really to mitigate suffering. And we sort of learn to recognize all types of suffering. That's not just about physical suffering. It's emotional and spiritual and anxiety and all the things that come with serious illness. And using communication to mitigate those things as well. So palliative care really can be used and often very helpful for patients who aren't going to die for years. Mm-hmm. Hospice is essentially palliative care, but administered to patients who are actually dying. They're within 6 months of death.
Thank you. So what is dying looking like right now with people who have COVID? I think it seems to me that it's changed a little bit since the beginning of it. And I know I have a couple of friends who've lost someone to COVID, and it seemed like they were able to be more present towards the end. But I'm curious what your thoughts are about that. I mean, in the beginning, we were talking about just how horrific and upsetting it was to think about people dying alone in their hospital rooms without having contact with their loved ones, nurses holding up FaceTime phones, and the hospital staff really not being prepared for the kind of emotions of having to see so many people through the end of life and their families. Has it changed at all, I guess, is my question, or are we still in that space?
We're still in that space. I mean, I think different hospitals are sort of maybe slightly changing their visitation policy. Some are becoming a little tiny bit more liberal. Ours hasn't. We really don't have visitors in the hospital. We have, end of life situations. We will allow one or sometimes two people at the bedside, but it's very, very it's very inflexible. But what's changed is we have started liberally using iPads and any form of communication. I mean, in the beginning of this, before we even had iPads, people were using their phones. That would never have happened before. We're so terrified about HIPAA. No one wants to give a patient or their family their phone number. That was happening left, right, and center. And then I want to just shout out to the Stutsky Foundation in San Francisco. They turned around a grant for us at Highland overnight. And that is, I don't know if I've heard of anything like that, for a huge, I don't think I should say the amount of money, so that we could virtualize our services. And that was a huge gift, and it really empowered us to do tremendously positive and productive things in our hospital.
That's amazing. I imagine in palliative care and obviously hospice, everyone who's on staff has a lot more experience with end of life and saying goodbye and helping families say goodbye and helping patients come to terms with end of life. But it seems like there's been a lot of scrambling in hospitals to step up that knowledge and that preparedness. And so how are they dealing with that? Do you know?
Well, I mean, again, I think each hospital is different. I was just on a call yesterday or the day before with New York City Health and Hospitals, all their public hospitals. And that was the place that I was volunteering. And I think probably maybe several other people on this call too, a lot of other palliative care practitioners were calling into New York and providing telepalliative care. And it's really interesting because I think we're still kind of orienting ourselves and trying to figure out how to do this. And I think what will come out on the other side of this will be protocols and procedures and practices. But I think that, some places are a little more ahead of the ball, and some are still kind of just struggling to stay on top. But I think that most places are starting to understand how important it is to provide visitation opportunities virtually for people. But we're still floundering a little bit.
Yeah. And I just imagine, I imagine all the nurses who were not familiar with having to have end of life conversations with patients, even on an emotional level or a practical one. But I'm hopeful that will become a better, deeper part of training.
Yeah, I don't want to sound pessimistic, but I will say that, still, I think that in the trauma of this pandemic and the rapidity of people coming in, especially as things surge, I don't know that we're doing everything that we need to do for people. And we still really need to make sure that we're getting our palliative resources to every patient that needs it. And I think using this sort of national telehealth, if we could figure out a way, the people who volunteered in New York, we're trying to volunteer in other parts of the country as this next surge goes up. And I just found out, I put my list on a name on a list, and I just found out that some of these other states don't want help. And I'm thinking, why? We're here for you. Let us help.
Wow. We still have a ways to go, I guess. What can lay people learn from the pandemic in terms of what can they be doing now, and what should they do going forward in order to prepare for end of life, even if it's not imminent for them or seemingly imminent?
This is sort of, we were talking about how having a pandemic can kind of inspire people to come and talk about grief and anxiety and talk about advanced care planning. And I think it's a combination of things that are going to be important here. We're going to have use the light and the fire of the pandemic to try to make it clear to people why advanced care planning is so important. But I also think that we want to make sure that we start to understand the importance of bringing this into civic education. People need to understand about planning for the end of life, just the way they understand about buying insurance for these, various types of things. And I personally think, and worked with my friend Dawn Gross, palliative care doctor here in San Francisco, to create a death education program for people who are in high school. I mean, why shouldn't an 18-year-old leave high school with an advanced directive? So it's a two-pronged approach, again, to thinking about advanced care planning. But your question is, what can people do right now in the face of COVID? And I really think it's important to realize, this is a serious and unpredictable pandemic. But life without a pandemic is also serious and unpredictable. So you want to prepare for it. But especially here, look what's happening in front of us. It's unpredictable. There are many, many things that a prepared person should be thinking about, planning for. It's not just, do you or do you not want to go on a ventilator? That's a very important question, especially for people with serious illness. But it's also, how are we, if you are going to be at home, who's going to be taking care of you? Let's plan our advanced care planning for the caregiver support that people are going to need. Who's going to take care of you if you have COPD and you decide, I don't want to go to the hospital if I get COVID? What's your plan? Have you talked to a hospice that might be available for you if you decide to start hospice? Is your daughter, who lives on 3 blocks away, going to be the person? How is this going to happen? So there's many types of advanced care planning that should be in your hopper to think about, just like your fire insurance and your other types of insurance that you think about as a responsible person.
It's amazing how resistant people can be to that kind of planning, though. I would imagine everyone here today with us is probably more inclined to think about those things and have those conversations. But even in my experience, my husband doesn't want to talk about this stuff. When the pandemic happened, I started working again on this ongoing file I have about my wishes, and all kinds of things are in there for what happens if I die. But he doesn't want to talk about it. And I sent it to him. He doesn't want to look at it. He doesn't want to do the same with his. What are ways we can try to engage people who are seemingly resistant?
Well, I mean, there's so many reasons why people might do that. And you're of all people, you're going to know those reasons, but just to list them, some people don't want to talk about it because they feel that it is disrespectful to the person who's telling them, I want to plan for my death. They, oh no, I'm not going to acknowledge your death because that will make you feel like I don't love you, or that'll make you feel like I want to get rid of you, or that I'm looking for your money. I mean, there's so many things that could be coming up in each family and each personal dyad. And I think one of the things that the person who does want to do that planning can say is, you will be respecting me and making me feel better to have this conversation. This is important to me. And really explain. And by the way, it's not just the dyad, it's not just the husband, it's your doctor. You know, my sister-in-law has very serious multiple myeloma, and she's got a palliative care doctor involved. And she's been having all of these conversations. We're hoping that it's not going to be an issue, but she's been saying, okay, now that COVID is here, you know, before I was willing to go and undergo cardiopulmonary resuscitation, at least for a trial period. Now I'm not so sure. I don't think I want to do that. So it's really important to make sure you're enlisting the people who are really important, your husband and your doctors, to really think about, to work through and step through that stuff with you.
Thank you. I keep bringing this up on pretty much every week. I want to keep hitting this home of that we need to have these conversations. A question I want to ask you and is about, you know, my work. I'm always working with families, individuals who've lost someone. So they're on the other end of the death, and they've been through the experience, whether it was an accidental death, a sudden death, or a long-term illness. And they're really trying to understand what happened and reckon with any suffering they may have perceived their loved one had. And I'm curious what you know at this point in your experience about suffering at end of life and death itself. And, you know, what's, you know, I've had some interesting conversations with BJ Miller about suffering and how sometimes as the loved one, we perceive suffering to be more than it is actually happening, which is an interesting concept and something that is important for me to think about when I'm counseling people who are trying to grapple with feelings of guilt or pain about this. And I'm curious what your thoughts are about suffering at end of life and death itself.
Well, I just took my palliative care board's recertification on Monday. It's incredible how much data there is on a variety of different types of suffering that can happen before someone dies that can translate into complicated grief and bereavement. And that suffering can include, you know, unaddressed physical suffering, emotions and depression of the patient, of the care recipient, suffering of the caregiver, and difficulty between that dyad. I mean, all of those things have been shown to translate into complicated grief for the person, the bereaved. And complicated grief following a death is a very serious situation with a lot of morbidity, physical and emotional morbidity for patients. And I think mortality, and although I'm forgetting, but I do believe it may have an impact on mortality as well. So our real important job, you know, as the people managing the person through the dying process, is to make sure that we've addressed every possible realm of suffering and done our absolute best to mitigate it. And that, again, is not going to just be housed with the care recipient, the patient, and all of their suffering, with emotional, physical, spiritual, et cetera, the total suffering and the total pain that they may experience. But it's also the persons in their lives, the family, the care provider, the family caregiver. If we've got to start, even we in the palliative care movement are not great at thinking about the care provider. And we are missing a lot of suffering that will then again translate into this tremendous bereavement period and possible complicated grief.
Tell us about your caregiver documentary, because that segues right into it though. And I was a caregiver myself for my father. You know, at 25, I was, you know, changing his bedpans and scrubbing his dentures and really, you know, getting up at 3 o'clock in the morning when he needed more pain meds. And I've lived it. And I agree that it's not acknowledged enough or thought about, or there's not enough put in place for it. So tell us about the work you've been doing in that area.
Well, I mean, it's funny, and I'm not proud of this, but I fell into it by mistake. Just like I fell into palliative care by mistake. I wasn't looking for it. I wasn't pushing for it from some internal, oh my gosh, I've got to think about the family caregiver. I fell into it by mistake. We had been, at the time that my book and Extremis came out, I had been filming my friend Bambi for sort of educational purposes. She had said, bring it on. She was a physician assistant. If my experience can help anybody, I want to help you. And I was filming her with the intention of showing how bringing hospice in makes everything better. And that happened for her in the first few days. She had been very, very sick with metastatic melanoma, terrible bowel obstruction, horrible pain, going in and out for radiation treatments that weren't even helping. We got her on hospice, and within, I'd say 48 hours, her quality of life exponentially rose. I mean, this woman went from being wanting to die to celebrating her life. Her sons all flew in. There was music, there was friends, and it was beautiful. And that's when we started filming. And I want to tell you that it was only 2 years after she died that I looked at the first rough cut of this film and said, oh my gosh, I was telling the wrong story. I wanted to tell a story about Bambi and how great hospice is, which it is, by the way, how great hospice is and how, the Jewish community were so good at doing death. And it was not the right story. The story is about Rick. And you watch in this film, which is 24 minutes, you watch this guy go from this sort of high, where everyone's on a high, and just proceed through 9 weeks of debilitation for him.
Yeah.
And it was unbelievable to watch. And there's a moment in the film where I say to him, well, Rick, I think you might need more support from hospice. And he looks at me and says, yeah, you know what they offered me? They offered me 2 45-minute breaks. And I look at him and my mouth is hanging over. So I'm thinking, number one, if I don't know about this, and I'm a palliative care doctor who advocates for end of life, if all this stuff, if I don't know about it, who the heck else doesn't know about it? And I started reading about it and learning about it and realized, oh my gosh, Rick was actually one of the lucky ones. He only did this for 9 weeks. Most people do this for an average of 4.5 years. Yeah. His care recipient was an appreciative person that they had a deep, supportive, mutually supportive relationship. Most people are taking care of patients with dementia, some of who don't recognize them, and many of whom have behavioral, which are all, by the way, risk factors for complicated grief. And it was absolutely shocking to me to realize that I had missed this entire rising epidemic.
So what do you think are some of the big changes we can start making around the caregiver space?
Well, I think the first thing is to raise awareness. I think, and this is the beautiful thing about storytelling, is that I don't need to provide people with the data. There's plenty of data to go around about this issue of caregiver burden and its morbidity, mortality, and devastation, and the fact that it's going to rise fast, and we've got to deal with this as a nation. There's data, abundant data. But the first thing you have to do is you have to make people want to know more. You have to make the stakeholders, like the employers, the healthcare insurers, the legislators, the communities who support, all be motivated to say, oh my gosh, I did not know that this was a problem. I better do something to fix this. I better collaborate with that group of stakeholders and collaborate. You've got to motivate people to learn more. And that's what I think film does. And that's what I think this film does. And I'm hoping that we will start with that first piece.
Amazing. Dara, maybe you can put a link to it in the chat for everyone.
Let me just say that the movie itself is not out. We're still running the film festival circuit, and people can watch the trailer. We're starting to create groups. We've created a pilot thanks to the Stupsky Foundation, again, a pilot for family caregivers that uses the screening of the movie. And we've created actually a lecture for healthcare professionals, which we just delivered to the American College of Physicians. So it's not available yet, but it's coming.
Thank you. You guys feel free to start putting in some questions or comments that you want to talk to Jessica about. And in the meantime, Jessica, tell us about your other book and your other documentary, or your book and your other documentary.
Well, my book, Extreme Measures, is a many years culmination of stories that I had been writing notes about, things that had, and some of which I never wrote notes about because they just blazed into my brain, the trauma of them all. I mean, I can't describe to you what it is like to, there's wonderful things about being an ICU doctor, many wonderful things, but there are many traumas. And these traumas, when you don't have any kind of an outlet to discuss them, to process them, to normalize yourself within them, can be traumatizing. And this book literally wrote itself. I mean, it just came out of me. I couldn't stop writing. The beautiful thing about it is that as you sort of bring all your stories to the surface, they separate themselves into themes. And there are just so many themes. You as a therapist know, it's so many things that impact the experience of a person going through serious illness, or someone who's watching a loved one going through serious illness. And I just think that what I hope that this book did was, it just, using stories, it just sort of spoke to many, many of the situations that people can find themselves in, and provided context for them.
Maybe Dara can put another link in there.
And then the movie, you know, again, it was, I have been writing my book, and I, every day I would walk into the ICU, and I just felt like I walk into these doors in the ICU, and then the doors close behind me. And nobody knows. I can tell, so I can write stories, but a lot of people don't read, let's face it. People need to see what's happening in here. We need to open the doors of these ICUs and let people in so that they can see it and be moved. Again, like I said about caregiver, moved to learn more, moved to change their own behaviors, and to really start advocating for themselves. And you know, they say a picture is worth 1,000 words. I will tell you, a movie is worth more than 1,000 pictures. And I think that bringing people into this place that is so, it's such a black box. And it's a black box that we think is a good thing. We think it's all good. Grey's Anatomy, ER, we just think of those people in there and those machines that are in there as really being good. And what we have to understand is it's much more nuanced, it's much more complex. And I think the movie shows that.
Thank you. I'm so appreciative of all this advocacy work that you do. We have a question here from Carrie. She says she lives in the Boston area, and we had wonderful palliative care support through our daughter's death. Now my father-in-law is in advanced heart failure and prostate cancer, and we can't get him palliative care help in Hartford, Connecticut. Why the discrepancy in care?
I'm so sorry to hear that. He absolutely needs and deserves to have a good palliative care team on his team. And there are many reasons why it might be hard to access care. It may be that the primary doctor is saying, oh, you're not ready for palliative care. We hear that all the time. Yes, you are, if you want it, if you feel that this would be a benefit, and clearly it has been a benefit to Carrie before. Don't let someone tell you you are not ready for palliative care. That is, any serious illness diagnosis like advanced heart failure, absolutely, if you want it, I personally feel that everybody should have access to the principles of palliative care, whether or not they ask for it, but certainly if you're asking for it. So if it's an individual physician who's keeping you from it, that's unacceptable, and you need to find a different physician. If it's because there isn't that much palliative care in that neck of the woods, which I can't imagine in Hartford, Connecticut, that there isn't. Let me just say that I can't imagine that in Hartford, Connecticut, you can't find palliative care. And I don't know, again, how Connecticut works, but again, in California, we have outpatient palliative care, we have home-based palliative care. I don't know what the laws are in Hartford, but I would absolutely start looking around for it. And I'm just sorry that you're struggling. It shouldn't be difficult.
I agree. I believe that BJ Miller just started a company that does consults about this, right? Dara, can you put a link in there for that? Like anyone around the country can reach out to his new company and get a consult on what should we do with, your father-in-law. And I think they have resources to help figure out no matter where you are. I believe.
Great.
Yeah.
That's so great. I love it.
That's it. Mentalhealth.com. Mm-hmm.
That's terrific.
Go ahead. Jessica Murphy says, I agree that people would benefit from seeing what it looks like. I used to work as an OT in the hospital and would see the same story repeatedly. I felt like I was torturing people and switched to work in hospice. I facilitate workshops now on prepping for death before one feels like there is an urgency to do so. I really like what you said about needing to motivate organizations to care. Do you have examples of how to motivate stakeholders to care?
Well, I had mentioned when I was talking about stakeholders, I was talking about care, people who are stakeholders in the issue of family caregiver burden. If you're talking about stakeholders in the end of life experience, I think many of those are already in understanding the importance and benefit. But again, it really varies from institution to institution, city to city. That whole Dartmouth Atlas project, which was started, I think, in the 80s, by looking at variability of care, really does show us that different cultures and communities and hospitals and practitioners are going to have different feelings about palliative care in general. And I think in some ways, I don't want to cop out, but it's a little too complicated to answer because it really depends on where you are in order to understand who the people are that hold the biggest levers for change.
I have a question about, one of the things that the pandemic has really illuminated is racial disparity at end of life. And I'm curious what you're seeing in your realm and what you think we can be doing or are already doing. It's really come to the forefront, obviously across the board in all kinds of ways, but particularly in end of life, and I think that is really something important to talk about.
It is a devastating reality of not only our healthcare system, but of our nation. It's this is baked into so many institutions, and it is most definitely baked into our healthcare system. African Americans have systematically been afforded worse care than white people. They've been neglected. They've been experimented upon. We have many examples of experimentation. They have been essentially denied access to many of our hospitals. They get less pain medication for the same types of things. The data is alarming. And at the end of life, what's fascinating is where in most realms we're talking about less intervention, less access, less care. The disparity at the end of life really has to do with using more intervention. So African Americans are getting more chemotherapy at the end of life. They're getting more ventilators at the end of life. They're more likely to die on machinery. And if you put it in the context of our nation and history, it makes perfect sense, because if you've been systematically denied care and mistreated by a system, you're going to want that system, if you have any choice in the matter, to do as much as it can for you. And what we all see is that more is better. That's sort of the American way. And so what I think, the number of NG tubes, for example, which in dementia, which have been shown to be actually cause problems, and in fact, early death in some patients, certainly a lot of morbidity, much higher rates of getting NG tubes in dementia for African Americans than for white people. This is really an important thing for us to acknowledge, and for us to empower the African American community to understand what it means. Most lay people don't really know what it means to have better care. What better care means is a deep and connected relationship with the healthcare team, which cares about you as a person and really tries to help pull out from you and then put into the center of the room the things that are most important to you. And when that kind of stuff happens, as we see with palliative care types of conversations, people tend, whatever their race, but anybody with that type of intervention tends to decrease the level of intervention, of non-beneficial interventions in their choices for healthcare. And African Americans just aren't having access to those types of conversations the same way.
I've been having this conversation with a lot of our guests, and I think it was Pastor Corey Kennard who was talking about trust on behalf of African American patients with healthcare providers, particularly at end of life, and not even asking or approaching, for palliative care or hospice, just because on a trust level, lacking that in such a big way. And then also hearing a lot about systemic racism just in the medical education that's going on for all medical personnel, which I think is a huge thing that needs to be addressed. What can we as lay people do to address any of this racial disparity in end of life? That's a tough question, I know, but is there anything that...
I'm going to be honest, what I'm finding, is that a lot of this is coming, the most, I think, effective work is coming from within the community. A white doctor can't easily come in and say, hey, you should do this. What needs to happen, and I don't know if you've interviewed Reverend Cynthia Prilliot. I don't know if you've heard of her. She is amazing. She's the make a note. She's an amazing woman who has started a group called the Alameda County Care Alliance in Oakland, which essentially works with faith communities. They've got this huge conglomeration of African American churches in Oakland, and they really work to empower the community to understand what many lay people don't understand about what I call the end of life conveyor belt, and about how to get the best care and how to think about your priorities and preferences before you're even interacting with the healthcare system. And one of the things that she and I are doing is we've taken Extremis, which, as you know, if you've seen it, mostly showcases African-American families. So I think it's a very relatable film for African-American communities, and created a discussion guide that really is aimed at faith leaders, not the congregants, but the faith leaders, the trusted faith leaders of those communities, to basically educate and inform them about what is the end of life. We have 4 modules. What is the end of life conveyor belt? What is the role of the faith leader? Mm-hmm. What is the role of faith in miracles? And let's talk about racial inequities. And what happened really about 2 weeks ago, we presented one of the modules, the discussion guide, which talked about what is the end of life conveyor belt? What are these machines? And what should you know about the machines? And one of the pastors, one of the deacons said, and in an angry voice, which I totally understood and agreed with, you should not be presenting about the end of life conveyor belt to us before talking about racial inequities. You should have used module number 4 first before you came in and talked to us about withholding and withdrawing, and when should you. He said that you first and foremost, talk about trust, talk about the stuff that's really there for us. And I was like, he is right. Yeah. Let's acknowledge this first before we even talk about trying to help people understand what's going on in an intensive care unit.
Wow. Brian has a question here. He says, I am an LMFT who works in a hospice and have been giving lectures to Master of Nursing students on how to have end-of-life conversations. And I'm so grateful universities find it important to include this in their curriculum. What is the #1 piece of advice you would give to nursing students?
Well, as someone whose 2 greatest mentors are a nurse, I mentioned Pat Murphy, and a chaplain Betty Clark, who I have worked with for 10 years at Highland, I will tell you that nurses have tremendous role in this. You have a perspective that is really different. Your training, and I'm not a nurse, so if I'm misspeaking, please forgive me, but my perception is that the training of nurses and the training of chaplains is really focused primarily on the person and on a patient-centered principles. And that is, as I've tried to describe, not what we in healthcare and medicine training get. And so nurses and chaplains and social workers play a very, very important role in helping to steer the culture of a hospital into something more humane. So I'm so happy you're doing what you're doing, Brian. And I really think that if you can figure out a way to collaborate and communicate with your physician colleagues, you will make that hospital and that training program a much more humane place. And Godspeed is all I can say.
Amazing. Nancy wants to know if there's a website where we can download the Extremis discussion guide.
So glad you asked that. It's so funny because someone else just asked for it. Who was it? Contra Costa Community Health Center, Public Health Hospital, just asked us this a few days ago. Can we use the Extremis discussion guide? And Cynthia and I are in conversation with them. It hasn't even been finished yet. We're still working on the graphic art, et cetera, et cetera. So it's not been finished. And actually, one of the things that we're going to be doing is we're going to be creating a non-paper discussion guide. We're going to be creating a second film. You watch Extremis. This is again for faith leaders. You watch Extremis, and then you watch this short film of Cynthia and I talking about, from the medical and the faith perspectives, all those 4 modules. And it'll be 15 minutes of filming, but we're going to stretch it out into an hour because we're going to have a lot of prompt questions for the group based on each of the modules. So it's not available yet. We're still working on it, but please stay tuned. Follow Jessica Zitter. Sign up for my newsletter, jessicazitter.com, and you will get updates about it when it's ready.
Thank you. I love this question from Marcia because I'm such an advocate for this, but can you see the professionalization of end-of-life doula, which is mostly a volunteer position? I'm so glad that this movement is getting bigger and bigger and that this role is getting bigger, but I think that's a great question. Could it be professionalized?
I love that you asked that question. Thank you, Nancy. No, thank
Marcia.
you. Marcia. I just spoke a week and a half ago at INELDA. I don't know if you know what INELDA is. INELDA is the End of Life Doula Association. I don't remember what it stands for, but what a fabulous and important role. And I was saying to this group, like, I want you at my bedside when I'm dying. I need an end of life doula at my bedside when I'm dying, please. And I absolutely think, and I said this at this conference, there is no, in an ideal world, there should be an end of life doula or two on every palliative care team or in every hospital. I mean, why wouldn't we? It is such an incredible benefit. Does my husband, if I'm dying at home on hospice, or if I'm dying in the hospital, does my husband or family know how to really help me through this? Have they ever seen this before? My husband saw his 95-year-old mother die and he was there, but does he really know what I would need? No. An end-of-life doula is someone who has professionalized this and has that core compassion that they bring there. It's a career volunteer position. It shouldn't be, but it is. Only people, it's like the early days of hospice. The only people who did it really care about that. And they are people we want at the bedside. Oh, I wish we could professionalize it.
Me too. This has been such an amazing conversation. What can you leave us with about heading into the next portion of this pandemic that we're heading into? How can we be facing this as lay people, just still trying to find something to hold on to, trying to figure out, our fears and anxieties about it, just find any kind of grounding here?
Well, the first thing I will say is we will get through it. Yes, people will die, and we have got to do everything in our power to minimize that. We've got to really listen to the scientists and do the things that we know work and try to protect ourselves, staying at home if we can, masking up and really doing good hand washing if we're first responders or we're frontline workers in grocery stores. We can keep ourselves safe. We know we can. So we have to listen to the science. We have to take care of ourselves, and we will get through this. And the human race is profoundly resilient for reasons that I don't understand, and we'll make it. We just need to take care of ourselves as best we can. And also, what I hope people will take from this is what we've been talking about a little bit. This is a wake-up call. It may be, oh, wow, there's this big pandemic, but this is all happening pre and post-pandemic. Death is real. And like everything else that we think about in our lives, if we're being proactive, we must think about what's important to us, mostly about how we live, but translate that into the way we want to make sure we are dying and able to die. And it's time to start doing that preparation now. This has been a wake-up call, but it will not end when this pandemic is over.
Thank you so much, Jessica. Where can we find you? Dara's been putting in lots of awesome links to you, but if someone wants to reach out to you, what's the best way? Twitter, email, or how do people contact you?
Well, I love talking to people. Go to my website first and foremost. If you're interested in hearing about any of this stuff, whether it's the extremist discussion guide, the work we're doing with Caregiver, et cetera, please go sign up for my website at jessicazitter.com. You'll see, and it gives you a free chapter first chapter of extreme measures. You can email me. There's email contact links on there, which I get them all. I'm so thrilled. I think we're building a very powerful movement, and I think we're all in this together. And I'm just so thrilled to be a part of this.
Thank you. I know I'm so grateful to everyone who's here today and willing and excited to have these conversations. And you guys are all ambassadors of this movement and of us, creating a better end of life. And of course, obviously to Reimagine for holding this space for it, because we wouldn't be able to have these incredible conversations and host this without Reimagine. So thank you guys. Thank you, Dr. Zitter. Thank you, Dara. Thank you, everyone who was here today.
Yes.
Thanks, everyone.